Welcome to the funnel effect. Today we're diving deep into a condition that, for a long time, sort of lingered in the shadows of cardiology. Tricuspid regurgitation, or TR. But things are changing, and fast. We're looking at the brand new expert consensus decision pathway from the American College of Cardiology. It's called 10 Issues for the Clinician in Tricuspid Regurgitation Evaluation and Management, and honestly, it feels like it's rewriting the playbook for TR.
It really is, and we should definitely acknowledge the huge effort behind this. Patrick O'Gara and Joanne Lindenfeld chaired the writing committee with a fantastic team. Rebecca Hahn, Megan Joseph, Omar Khalik, Pratiti Kazani, Dharam Kumbani, Robert Page, Kristen Patton, and Vinod Tharani. Plus, essential oversight from Guru Sharpandrath, Nicole Bave, and the whole Solution Set Oversight Committee. It's a major synthesis of recent evidence.
Absolutely. So our mission today for you, the listener, is to unpack these 10 critical issues. Think of this as your essential update on TR, where it stands now, why it matters more than ever, and how treatment is being completely revolutionized. Let's get started. So, first off, why the sudden urgency around TR? It wasn't always front and center. What's changed? Let's talk scale.
Well, the scale is surprisingly large. We now know TR affects about 4% of people age 75 or older. If you translate that, it's roughly 1.6 million people just in the U.S. with moderate or even greater TR. So it's not rare at all.
Okay, 1.6 million, that's significant. But prevalence alone doesn't always create urgency. What about the impact?
That's the crucial part. The old thinking was, well, TR is just a consequence of other problems, maybe not so bad on its own. But the evidence now is overwhelming. Increasing TR severity is directly linked to higher morbidity and, importantly, higher mortality. It's an independent risk factor.
Independent, even after accounting for things like left heart function or pulmonary hypertension.
Exactly. And here's the real kicker, the thing clinicians really need to absorb. This isn't just about severe TR. Studies highlighted in the pathway show that even mild to moderate TR is associated with worse long-term outcomes. We can't just dismiss it anymore.
So it's acting like a silent amplifier of risk, even at lower grades.
Precisely. It makes other existing heart conditions worse.
This feels like TR is finally catching up to other valve diseases in terms of focus.
Yeah.
We saw TAVI revolutionize aortic stenosis treatment.
Right. TAVI is mature now.
Then MTIR, the mitral clip procedures, really took off for mitral regurgitation.
Yes, MTIR found its place. TR has definitely been the, let's say, the third wave in this transcatheter valve revolution. For years, the only option was complex, high-risk surgery, often done way too late. But now, there's been this explosion of clinical investigation.
Better imaging, a clearer picture of the natural history.
And crucially, the development of dedicated devices specifically for the tricuspid valve. The field has matured incredibly quickly.
Which brings us to what the ACC document calls a real aha moment, the regulatory approvals in 2024 and 2025. Tell us about those.
This was huge. In 2024, the FDA approved 2 transcatheter systems, TriClip, which is a TT-ear, or edge-to-edge repair system.
Similar to the mitral clip concept.
Yes, and EVO Key, which is a dedicated transcatheter tricuspid valve replacement, or TTVR system. And the key point, the really transformative part, was the indication. They were approved specifically to improve health status, meaning symptoms and quality of life, QL, in patients with symptomatic severe TR.
Quality of life is the primary goal, not reducing death or hospitalizations. That feels different for a major cardiac device approval.
It is different, and it reflects the reality of these patients. They are often elderly, quite frail, with many other health issues. Their primary burden is the symptom load from chronic venous congestion, the swelling, the fatigue, the inability to function. Proving a mortality benefit in that specific population with interventions would require enormous, very long trials. The FDA, guided by the emerging consensus like this pathway, essentially said, look, improving debilitating symptoms and QL in a chronic condition with no other effective medical therapies is a valid and worthy treatment goal in itself.
It's a landmark perspective, really acknowledging the patient's daily suffering.
It absolutely is. And it gave clinicians a mandate to treat the symptoms aggressively.
And this was backed up by the CMS coverage decision soon after, wasn't it?
Yes. In March 2025, CMS approved coverage for TTVR under coverage with evidence development, basically ensuring access while collecting more real-world data. A similar decision is expected for TTR, so the devices are approved, and importantly, they're getting covered. It signals that intervening to improve QL in TR is now firmly part of standard care pathways.
Okay, so we know TR is important and treatable, but the ACC pathway really hammers home the need for precision. We can't just call it functional TR anymore. We need to know the why. How does the new classification help?
It's fundamental. Understanding the cause, the etiology, dictates prognosis and treatment. The pathway outlines three main types. First, there's primary TR. This means the problem is with the valve leaflets or the chordae themselves. Think infections like endocarditis or congenital issues like Epstein anomaly. The valve structure itself is abnormal.
Okay, that seems straightforward. But most TR we see isn't primary, right?
Correct. The vast majority is secondary TR, sometimes called functional TR. But even that term is too broad now. The critical distinction is what's causing the valve to leak secondarily.
And that leads to the VSTR versus ASTR classification.
Exactly. This is probably one of the most important clinical takeaways. Secondary TR is split into ventricular secondary TR, VSTR, and atrial secondary TR. They have different drivers and different implications.
Break those down for us. What's VSTR?
VSTR is driven by the right ventricle, the RV. Typically, this happens because of pressure or volume overload, often from left-sided heart disease, pulmonary hypertension, or maybe a primary RV muscle disease. The RV dilates, it stretches out, and its function often declines. This pulls the papillary muscles outwards and downwards.
Tethering the leaflets.
Precisely. It causes leaflet tethering. The geometry changes, so the leaflets just can't close properly during systole because the RV chamber is too big and distorted.
So VSTR is RV problem causing valve leak. What about ASTR then?
ASTR is different. It's often driven by problems primarily affecting the right atrium. The RA, chronic persistent atrial fibrillation, AF, is a classic cause, or sometimes HFpEF. Here, the main issue is massive dilation of the RA, which in turn stretches the tricuspid annulus, the ring the valve sits in.
So the door frame gets too big for the doors.
That's a great analogy. The annulus dilates significantly, leading to a central leak. Crucially, in many ASTR cases, the RV size and its pumping function might actually be relatively preserved, at least initially.
And that difference in RV status must impact prognosis, right?
Hugely. VSTR, especially when it's linked to advanced left-sided heart disease or significant RV dysfunction, generally carries a worse prognosis than primary TR or ASTR. Knowing the mechanism helps us understand the trajectory and tailor the intervention. Are we dealing with a sick RV or mainly just a stretched annulus? Very different scenarios.
Okay, classification is key. Now let's talk about assessing severity. We use echo, TTE, as the first-line tool, but the pathway points out some major limitations, especially with traditional methods.
Yes, quantifying TR accurately is much trickier than, say, aortic stenosis. The tricuspid valve is complex, asymmetric, and its function is very sensitive to loading conditions. The big problem the consensus highlights is the standard proximal isovelocity surface area, PSA, calculation.
Why does PISA struggle so much with secondary TR?
PISA math relies on geometry. It assumes the area where the blood flow speeds up as it approaches the leak forms a nice hemisphere, and that the hole itself, the regurgitant orifice, is circular. In VSTR, with those tethered leaflets creating more of a slit-like opening, those assumptions just completely break down. The flow pattern isn't hemispheric. The orifice isn't round.
So the calculation is based on faulty assumptions for this specific condition.
Exactly. And the consequence is significant. The consensus states that conventional PISA can underestimate secondary TR severity by as much as 50%. 50%.
Wow. That means patients might be labeled moderate when they actually have functionally severe or even worse TR. That explains late referrals.
It's a major contributing factor, yes. Clinicians need to be aware of this limitation and look at multiple parameters, not just PISA EROA.
If the old severe 3+ category isn't enough, especially with this underestimation issue, we need a new way to describe the really extreme cases. This leads to the expanded grading scheme.
Correct. The traditional mild 1+, moderate 2+, severe 3+ scale isn't granular enough at the top end. We now need to use an expanded scheme that includes massive and torrential TR.
Let's get specific. What defines severe 3+ quantitatively?
The threshold for severe is still a vena contracta width of 0.7 centimeters or more, or an effective regurgitant orifice area, EROA, greater than 0.4 centimeters or a regurgitant volume RVOL of 45 millimils per beat or more.
Okay, standard severe. Now, what pushes it into massive or torrential? These are the terms clinicians need to start using.
These terms reflect the kind of extreme TR we were seeing in patients enrolled in the big transcatheter trials, patients who are incredibly symptomatic. Massive TR is generally defined by an EROA between, say, 0.55 and 0.74 centimeters or greater, or an RVOL between 60 and 89 LM beat. And torrential TR is the absolute upper limit, an EROA of 0.75 centimeters or greater, or an RVOL of 90 millibet or more. These are huge volumes leaking back with every beat.
And recognizing these, perhaps using 3D echo or other methods that are less piezo-dependent, is crucial for risk stratification.
Absolutely. Identifying massive or torrential TR signals a very high-risk patient who likely needs urgent consideration for intervention. It moves them up the priority list.
Understanding severity naturally leads to assessing the impact on the heart, especially the right side. The ACT pathway stresses that a detailed right heart evaluation is absolutely critical. How do we best assess the RV given its awkward shape?
Yeah, the RV's crescent shape makes simple geometric calculations difficult, unlike the LV. So on TTE, we rely on specific functional measures. The two key metrics for RV systolic dysfunction mentioned are TPSE, which is tricuspid annular plane systolic excursion.
How much the side of the valve ring moves up and down.
Exactly. A TPSE less than 17 millimeters suggests poor contraction. The other is S velocity, the speed of that annular movement measured by tissue Doppler. And S velocity below 9.5 centimeters per second also indicates dysfunction. Low numbers mean the artery isn't squeezing well longitudinally.
But TTE still has limitations due to that shape and maybe acoustic windows. Does advanced imaging help fill the gaps?
Definitely. This is where cardiac magnetic resonance, CMR, really comes into its own. The consensus recognizes CMR as the gold standard, the most accurate, non-invasive way to measure RV volumes, both end diastolic and end systolic, and calculate the true RV ejection fraction, EF.
So if the echo is unclear, or if you're planning a complex intervention like TTVR,
CMR can provide invaluable baseline data and clarify the extent of RV damage and the true amount of regurgitation.
and these quantitative measures tie directly into prognosis, right?
Yeah.
What CMR findings signal really high risk.
Yes, the pathway links specific CMR numbers to outcomes. A CMR-derived regurgitant volume, RVOL, of 45 ml or more, or regurgitant fraction RF of 50% or more, meaning half or more of the blood pumped by the RV, is leaking backwards. These are associated with the highest one-year mortality risk.
That really reinforces the severity scale. That degree of volume overload is incredibly dangerous.
It is. It puts immense strain on the entire system.
Let's talk more broadly about the natural history. The document confirms TR is linked to excess mortality, independent of other factors. Just how bad is developing severe TR?
The data is stark. Large studies show that if severe TR develops during follow-up in patients who didn't have it initially, their adjusted hazard ratio for all-cause mortality jumps to 2.44.
So more than double the risk of dying compared to someone who stays TR-free.
Correct. It underscores why letting TR progress unchecked is so detrimental. We need to identify and manage it earlier.
The pathway also mentions different clinical phenotypes based on a cluster analysis by Anand and colleagues. Why is recognizing these patterns useful?
It helps with prognosis and understanding risk drivers. That analysis found 5 distinct groups of TR patients based on their clinical features and heart parameters. The most sobering finding was the cluster strongly associated with chronic kidney disease, CKD. Those patients had shockingly high 5-year mortality rates, up to 83%.
83%.
Yes. It highlights a critical point. Once the chronic venous congestion from TR leads to significant advanced kidney damage, the prognosis becomes dismal. The kidney dysfunction is both a result of the TR and a powerful independent driver of mortality. The window for effective intervention might be closing fast at that point.
And we shouldn't forget about CID-related TR. That carries its own risk, too.
It does. Having a pacemaker or defibrillator lead crossing the tricuspid valve is independently associated with increased risks, an adjusted hazard ratio of about 1.52 for all-cause mortality and 1.82 for heart failure hospitalizations.
Whether the lead itself is causing the leak or maybe RV pacing is causing remodeling.
The presence of the lead is a negative prognostic factor. It complicates things.
To help manage all this complexity, the pathway suggests using clinical risk models. How should teams use scores like the TRO-RV score?
These scores are practical tools for the multidisciplinary team, the MDT. They integrate easily available information like age, kidney function markers.
Things like creatinine over 1.4 or eGFR below 30.
Exactly. Those kinds of thresholds indicating CKD. And they combine that with measures of RV function, like TPSE or S. By calculating a score, the team gets a more objective estimate of the patient's 1-year or 3-year mortality risk. This helps guide conversations about the urgency of intervention, potential benefits versus risks, and maybe even the need for prehabilitation to optimize the patient before a procedure. It aids shared decision-making.
Okay, so the prognosis can be grim, especially if TR is severe or the patient has high-risk features.
Yeah.
What about medical therapy? You mentioned earlier there are no specific drugs for TR itself.
That's right, and it's a crucial point. Unlike HFrEF, where we have GDMT, there are no specific disease-modifying therapies that directly target the tricuspid valve leak or its progression. So medical management boils down to two main goals. First, treat the underlying cause if possible, manage the heart failure, control the atrial fibrillation, address the pulmonary hypertension. Second, and this is paramount, manage the volume overload with diuretics.
Dealing with the symptoms, essentially.
Yeah. Primarily, yes, because the misery of TR comes from that systemic venous congestion, the edema, the ascites, the fatigue. So aggressive decongestion is cornerstone therapy.
But getting rid of fluid in these patients is notoriously difficult. They often become diuretic resistant. Why is that?
This is a key pathophysiological link the consensus clarifies well. Severe TR causes high pressure in the right atrium, which backs up into the entire venous system, including the veins draining the kidneys. This leads to renal venous hypertension.
High pressure in the kidney's drainpipe.
Exactly. And that high back pressure physically opposes the kidney's ability to filter fluid out into the urine. The pressure gradient needed for filtration is reduced or lost.
So the diuretics might be telling the kidney to excrete fluid, but the plumbing is blocked downstream.
That's a perfect way to put it. It blunts the effect of diuretics, leading to resistance. This worsens the congestion, which further worsens renal function, creating a vicious cycle. This cardiorenal syndrome component is why advanced kidney disease is such a poor prognostic sign in TR.
Given this challenge, what are the recommended strategies for decongestion when patients become resistant?
The pathway suggests a stepped approach. First, ensure you're using diuretics with high and reliable bioavailability, like torsemide or bumetanide, rather than oral furosemide, which can have erratic absorption, especially in congested patients. Sometimes continuous IV infusion is needed in acute settings. Second, think about dual nephron blockade. Adding a thiazide-type diuretic, like metolazone, targets a different part of the kidney tubule than loop diuretics, giving a synergistic effect.
Hitting the kidney at 2 points.
Right. Third, newer strategies are emerging. SGLT2 inhibitors, now foundational in HF, generally also have diuretic effects. And using acetazolamide, which works on the proximal tubule, can sometimes help overcome resistance, particularly in the setting of metabolic alkalosis, which can develop with aggressive loop diuretic use. It offers another mechanism to enhance fluid removal.
Beyond diuretics, optimizing treatment for any underlying left-sided heart failure is still critical, even if the main problem seems to be TR.
Absolutely essential. Don't neglect the basics. Proper guideline-directed medical therapy, GDMT, or HFrEF or HFpEF, the beta blockers, ARNIs or ACE inhibitors, MRAs, SGLT2 inhibitors helps the left side, which in turn can reduce pulmonary hypertension. Reducing pH lowers the pressure load on the RV. This can lead to favorable RV remodeling and actually lessen the severity of VSTR. So treating the left side often indirectly helps the right side and the tricuspid valve.
Makes sense. What about rhythm control, specifically for atrial fibrillation, a key driver of ASTR?
AF is tightly linked to TR, especially the ASTR form with annular dilation. The longer someone is in AF, the more the RA and annulus tend to stretch. So restoring and maintaining sinus rhythm through cardioversion or more durably catheter ablation can actually lead to reverse remodeling. The RA can shrink, the annulus can tighten slightly, and the TR severity can decrease.
So rhythm control can be valve therapy in a way.
In some cases, particularly ASTR, yes. But there's an important caveat. The success rate of AF ablation tends to be lower in patients who already have long-standing significant TR. The enterium might be too structurally damaged.
Another argument for earlier intervention. Address the AF before the TR becomes chronic and severe.
Precisely. It highlights the interplay between the arrhythmia and the valve disease and the need to manage both proactively.
Since medical therapy is mainly supportive, intervention becomes crucial for symptomatic severe TR. Let's start with the traditional approach, surgery. Particularly, what about fixing the tricuspid valve when operating on another valve, usually the mitral?
Right. Concomitant TV repair during left-sided surgery, most often mitral valve surgery, is the established standard if the patient already has severe TR. But the really interesting recent development, highlighted by the Gami et al. Trial discussed in the pathway, concerns prophylactic repair fixing less severe TR.
You mean operating on moderate TR or even mild TR if the annulus is dilated just because you're already doing mitral surgery?
Exactly. That trial randomized patients undergoing mitral surgery who had moderate TR or mild TR with a dilated annulus, defined as 4.0 centimeter, to either get the mitral surgery alone or mitral surgery plus a tricuspid valve repair, usually an annuloplasty ring. The results were quite clear. Adding the prophylactic TV repair significantly reduced the risk of the TR progressing later on. At 2 years, only 3.9% of the repair group developed moderate or severe TR compared to 10.2% in the mitral-only group.
So it prevents future worsening of the TR. Sounds good.
It does prevent progression, but there was a major trade-off identified in that trial.
The catch. What was it?
Permanent pacemaker implantation, PPL. The risk was dramatically higher in the group that got the concomitant TV repair. It jumped from 2.5% in the mitral-only group to 14.1% in the group that had both valves addressed.
14%. That's a huge increase. Why does repairing the tricuspid valve surgically carry such a high risk of needing a pacemaker?
It's anatomy. The tricuspid annulus, where the surgeon places sutures or an annuloplasty ring, is very close to the AV node and the bundle of his critical parts of the heart's electrical conduction system. Surgical manipulation in that area can easily cause inflammation or direct injury, leading to heart block and the need for a permanent pacemaker.
So you might prevent future TR, but at the cost of potentially needing lifelong pacing. That's a tough conversation.
It is. It's a major factor in decision-making, especially for prophylactic repair.
What about surgery purely for isolated TR when the tricuspid is the only valve being operated on?
Isolated TR surgery has historically been viewed as very high risk. Early mortality rates used to be quoted around 8% to 10%. A lot of that was likely due to very late referral. Patients often came to surgery only when they had advanced RV failure, severe kidney or liver dysfunction, what the pathway calls features of poor prognosis. Recent data suggests outcomes have improved somewhat, maybe closer to 5.6% mortality now in experienced centers, but the consensus remains clear. Isolated TR surgery is still a high-risk procedure, often undertaken in very sick patients.
Which perfectly sets the stage for the transcatheter options designed for these higher-risk patients. Let's unpack the two main approaches approved: T-tier repair and TTVR replacement. Start with T-tier, like the TriClip device studied in Triluminate.
Right. T-tier uses clips to grasp the tricuspid leaflets and pull them together centrally, reducing the leak, similar idea to the MetroClip. The pivotal Triluminate trial compared T-tier plus optimal medical therapy, OMT, against OMT alone in patients with severe TR. The results showed T-tier was superior, with a win ratio of 1.48. And as we discussed earlier, this win was driven almost entirely by improvements in quality of life.
How much did QL improve?
Significantly. The average score on the Kansas City Cardiomyopathy Questionnaire, KCCQ, a key measure of heart failure symptoms and quality of life, went up by 12.3 points in the T-tier group. In the OMT group, it barely changed, only 0.6 points. That 12-point difference is considered very clinically meaningful.
Patients felt substantially better. Did it actually reduce the leak effectively?
Yes, it was quite effective at reducing the severity. At 30 days, 87% of the T-tier patients had their TR reduced to moderate or less. So it provides symptom relief backed by a durable reduction in regurgitation for many patients, especially those with suitable anatomy.
Okay, now let's switch to TTVR, the replacement strategy, using a dedicated valve like the EVO-E system studied in Tricuspid II.
TTVR aims for a more complete elimination of TR by implanting a whole new valve within the native annulus. The Tricuspid 6 trial also compared TTVR plus OMT versus OMT alone. It also showed superiority for the intervention with an even higher win ratio of 2.02. Again, the primary drivers were improvements in QL and functional status, like NYHA class.
And how well did it stop the leak compared to T-tier?
Even more effectively, which you might expect from a replacement. An impressive 95.3% of TTVR patients had their TR reduced to mild or less. It achieves near complete elimination of regurgitation in most cases.
That sounds incredibly effective. But we talked about the pacemaker risk with surgery. What about TTVR?
Ah, yes. Here's the major downside for TTVR, and it's even more pronounced than with surgery. The rate of new permanent pacemaker implantation was extremely high, 24.7% within 30 days.
Wow, nearly 1 in 4 patients needed a pacemaker after TTVR.
Correct. That's a sobering statistic. The mechanism is thought to be the physical presence and outward force of the large, self-expanding TTVR valve frame pressing against the tricuspid annulus and irritating or compressing the nearby conduction system.
So you get excellent TR reduction, but at a very high cost of potential pacing dependency. This makes the choice between T-tier and PTVR really complex for the heart team, doesn't it?
Incredibly complex. The decision really has to be individualized by the multidisciplinary team, MDT, weighing anatomy, procedural risk, patient preference, and long-term implications like anticoagulation.
What factors push the MDT towards T-tier?
T-tears is generally preferred if the valve anatomy looks suitable for clipping, specifically a relatively small gap between the leaflets when they try to close, the coaptation gap, ideally de leave of 7 Texment. Also, if the leaflets aren't too thickened or restricted, and very importantly, if the patient cannot or prefers not to take long-term anticoagulation, which is currently required for TTVR but not TT-tear.
And when does TTVR become the better, or maybe the only option, despite the pacemaker risk?
TTVR is often considered when the anatomy is challenging for repair. Think of a very large coaptation gap, 7 millimeters, severely tethered or thickened leaflets where a clip likely won't work well, or if there's poor visualization on echo making T-tear difficult. Another key scenario favoring TTVR is CIE-related TR, where an existing pacemaker lead is interfering with the native valve function. TTVR can sometimes accommodate the lead better than repair, although it introduces other lead management issues we should discuss.
Yes. Let's definitely talk about those cardiac implantable electronic devices, CIEDs. They cause TR, and they complicate fixing it. If a patient has CIED-related TR, why isn't just taking the lead out the simple answer?
Lead extraction sounds logical, but it's far from simple and carries significant risks, especially for older leads. The longer a lead has been implanted, the dwell time, the more it becomes fibrosed, basically scarred onto the heart tissue and the valve structures. Trying to pull out a lead that's been in for, say, over 15 years carries a risk of acute TV injury or even avulsion, tearing the valve that approaches 20%. That's a potential catastrophe requiring emergency surgery.
20% risk of tearing the valve. That's huge.
It is. And often, even if extraction is successful without immediate damage, the TR might only partially improve. So the benefit is unpredictable while the risk is substantial. It has to be considered very carefully, usually by specialized extraction teams.
If extraction is too risky and the patient proceeds to TTVR, you mentioned the issue of jailing the existing lead. What does that mean for the patient long-term?
Jailing occurs when the TTVR frame expands and traps the existing pacemaker or ICD lead between the metal struts of the new valve and the heart wall. This creates two major problems. First, it makes future extraction of that lead, for example, if it gets infected years later, extremely difficult or impossible without potentially damaging the TTVR valve. Second, the constant pressure and friction can damage the lead itself over time, causing insulation failure or conductor fracture, leading to lead malfunction.
So you solve the TR problem, but potentially create a future lead management nightmare.
It's a significant concern. This is why the consensus pathway strongly advocates considering non-transvalvular pacing options whenever feasible, especially if TV surgery or TTVR is planned.
What are those alternatives?
Things like leadless pacemakers that sit entirely within the RV cavity and don't cross the valve, pacing leads placed in a coronary sinus branch on the left side of the heart, or traditional epicardial leads placed on the outside surface of the heart during surgery. Avoiding a lead across the tricuspid valve altogether prevents these future complications.
Okay, let's shift gears slightly. After a successful intervention, whether TTR or TTVR, the leak is significantly reduced or eliminated. What happens immediately to the heart's hemodynamics? The pathway warns about this.
Yes, the post-intervention hemodynamics can be tricky. Think about the RV. For years, it's been pumping a large amount of blood backward into the low-pressure right atrium. That leak was acting like a pop-off valve. When you suddenly close that leak, especially with TTVR, which is very effective, the RV experiences an abrupt increase in afterload.
Meaning it suddenly has to push all its blood forward into the higher pressure pulmonary artery.
Exactly. It loses its low-resistance escape pathway. For an RV that might already be weak or dilated from chronic volume overload, this sudden demand can be a shock. It can lead to temporary RV dysfunction or failure right after the procedure, sometimes requiring intensive support.
That sounds concerning. But the long-term hope is actually the opposite RV reverse remodeling, right?
Correct. Despite that initial afterload challenge, eliminating the chronic volume overload allows the RV to gradually recover over weeks and months. Studies show RV dimensions typically decrease. And importantly, this helps the left ventricle too through something called ventricular interdependence. A massively dilated RV pushes the septum, dividing the ventricles over into the LV cavity, squashing it and impairing its filling.
So a sick right heart hurts the left heart.
Yes. When the RV shrinks after successful TR intervention, the septum moves back to a more neutral position, allowing the LV to fill better and pump more effectively. This septal shift contributes significantly to the patient's overall symptomatic improvement.
Finally, let's touch on managing these patients after the procedure, specifically heart failure management and ensuring they leave the hospital truly decongested or euvolemic. Why is this so difficult?
It's challenging because simply relying on symptom relief or weight loss can be misleading. Patients might feel better because the overwhelming TR is gone, but they can still have significant residual congestion, especially systemic congestion that isn't always obvious from just listening to the lungs. And leaving the hospital congested is a major predictor of poor outcomes and early readmission.
So how does the consensus recommend assessing volume status accurately before discharge?
It calls for a holistic, integrated assessment using multiple data points. Don't just rely on one thing. Combine the clinical status, look carefully at the jugular venous pressure, JVP, check for residual edema or hepatomegaly, add imaging markers, use ultrasound to look at the inferior vena cava, IVC. Is it still dilated? Does it collapse normally with breathing? Use point-of-care lung ultrasound to look for B lines, which indicate fluid in the lung tissue. And finally, incorporate biomarkers like BNP or NT-proBNP levels. If the JVP is still high, the IVC is plump and doesn't collapse, and there are B lines on lung ultrasound, even if the patient feels okay, that strongly suggests they are still congested and need more diuresis or optimization of their GDMT before going home.
It's about putting all the pieces together to ensure the benefits of the intervention aren't undermined by residual congestion.
Exactly. Effective decongestion is absolutely key to durable success. So perhaps to wrap things up, we can quickly revisit the 10 key practice objectives that the ACC pathway really wants clinicians to take away. It's about screening proactively for TR, especially in patients with risk factors like left-sided disease or CIEDs. It's about defining the etiology, mechanism, and severity, precisely using that V-stray STR distinction and the expanded massive torrential grading scale, leveraging advanced imaging like CMR or CT when needed. It's about aggressively managing the underlying causes, optimizing HF meds, controlling AF because we lack TR-specific drugs. Crucially, refer patients early to the MDT before irreversible end organ damage like severe RV failure or kidney liver dysfunction sets in. Collaborate closely on CIED management, understanding the risks of extraction and the high PPL rates with intervention. And finally, always use shared decision-making, counseling patients that the primary goal, especially with current transcatheter therapies, is often a major improvement in their quality of life.
That's an excellent summary of a truly practice-changing document. The data is clear. We can now intervene effectively on TR, especially for QOL, but these interventions, particularly surgery and TTVR, come with that significant baggage of pacemaker implantation, 14% for concomitant surgery, nearly 25% for TTVR. Which leads me to a final provocative thought for you, our listener, to consider as this field continues to evolve. How might the increasing availability and use of non-transvalvular pacing systems, like leadless pacemakers or subcutaneous ICDs, change the risk-benefit equation for TR intervention in the future? If we can reliably provide pacing without crossing the tricuspid valve, potentially avoiding lead-induced TR, eliminating extraction risks, and maybe even reducing the pacemaker risk associated with TTVR compression, does that fundamentally alter how early or how aggressively we might consider intervening on TR? Could it allow us to treat patients sooner, preserving RV function before it's too late? Something to watch closely. Thank you for watching The Funnel Effect.